they've given me the assignment of talking about the quality reporting program, going over the requirements, the definitions, and the actual assessments that we've all been coping with for a number of years. When we're done with our time together this morning, hopefully everyone here is going to be able to go back and explain to their staff what the definition of a quality episode is, the 5 Medicare Post-Acute Care Transformation Impact Act quality measures that are included in the quality reporting program, and to be able to discuss with your staff what measures have been removed and why. We're going to look at terminology. We're going to be able to define these particular pieces, these particular items for your staff. And I want to emphasize, I'm an educator at heart. And so as I go through my presentation, not just this morning, but tomorrow, a lot of times I know that everyone in this room knows this information. You've worked with this, you've worked with your staff. But I'm going to try to give you some examples and some definitions, some terminology that you can take back with you. Not because you necessarily needed me to tell you what the definition of the beginning and end point of an episode of care is, because you know that. But you're the people who have to go back and teach this to new staff, to staff that are not new to home care but new to you and who may have habits you want to educate and remediate. So I'm trying to give you some tools to work with. And throughout the next 2 days, over and over, you're going to hear us saying, how will you take this back? How will you use this when you go back to your agency? How will you go about teaching this to your staff in a way that they will not only understand, but they'll get past the, yeah, I heard that already. Because we have to get past that barrier so that they will truly buy in and make improving the quality and the outcomes of care their mission as they go out and take care of their patients every day. So we're going to identify these terms and be able to define them comfortably. We'll be able to list out the OASIS time points and what assessments are done when and why. We'll look at data submission requirements. We'll talk a little bit about the consequences of not meeting pay-for-performance rules. We'll identify what resources are available to you, including the final data set, the manual, the Q&A, and the quality reporting measure tables and the specifications for them. The next 2 or 3 slides is a list of the acronyms, the abbreviations that we're going to use throughout today and tomorrow. I would make a suggestion to you here. If you take these slides and create for yourselves a teaching tool so that you can now take this back and use this to educate and orient your staff to a quality approach to providing care. Little side story. I've been with Qualidigm for over 10 years now. About 3 weeks into my initial orientation, I went into my manager and I said, okay, I have 2 master's degrees to hang on my wall. I'm not dumb, but I am sorry, you all speak a language I never heard before. You use all these acronyms, you throw out these letters, everybody else seems to know what y'all are talking about. I haven't a clue. It's not going to make sense to your staff if they don't know what you're talking about. They'll recognize CHF, COPD. They understand that. They understand sock and rock, I hope. But there are a lot more terms on these slides that they haven't heard of, that they're not routinely familiar with. Home health compare. They may have heard of it, but have they seen it? Have they actually gone and looked at it? These are very important things that you can and should spend some time going through them with your staff. If you do, you'll find it is time well spent, because the more that they buy in, the more that they're going to actively work to achieve the goals that we all have. So as I said, there are at least 4 different slides with all of these acronyms. Use them. Put no more than 3 to 5 words as the definition for each one of them, and use that as a teaching tool. If nothing else, make sure that every one of them has it in hand. Let's turn our attention to the quality reporting program itself. The QRP was begun on January 1st of 2007. Doesn't that seem like a really long time ago? Home health data was collected, and it was using the very first OASIS data collection tool. I remember teaching nurses for the first time to use it and hearing all the screaming and yelling about, I counted it, there's over 100 questions on here. Remember that? Fortunately, electronic medical records have taken the sting out of that, but it's still over 100 questions. To create useful data, your agency needs to submit a minimum of 2 matching OASIS assessments for each patient. These assessments together create what's called the quality episode. When I first started teaching this to nurses, I found that the most useful visual for them was to simply say, a quality episode is a window in time. You've got a left-hand curtain, that's your sock and your rock. You have a right-hand curtain, that's your transfer and or discharge. That closes in that episode, that window into the care that you provided. It's a visual they can understand, and it will begin to make more sense to them. So these quality episodes form the information, the data, that gives you the information about how your agency performed in the quality measures. Since the fall of 2003, CMS has posted a subset of a group of selected OASIS-based quality performance information on the Home Health Compare website. Does everybody remember, were all of you in home health at the time? Do you remember when that first came out? The very first set of data out on Home Health Compare, and we were all in a dither because, oh my God, the public is going to see our results. And we all sweated and worried. I know in Connecticut, they posted our rankings, each agency, on the front page of the local papers. And we all waited for the phone calls, and none of them happened because the public didn't know then what they know now. And they weren't as computer savvy. Now, our referral sources, our family members, are looking this information up. So it's critical that we not only know what it is, but how to react to it. The publicly reported measures included outcome measures that say how well the agency is helping the patient to regain or maintain their ability to function. An outcome measure is the end result. A process measure evaluates the rate of the agency's use of specific evidence-based processes of care. In other words, process measures are the how. This looks at how you did what you did. Alan went over this detail in this slide. I'm not going to take up time here this morning to go over it again. It's very tiny print. Blow it up much bigger. Take some time to look at it and understand where we are in the process and where we need to be. January 1st, 2017. Last fall, when we were teaching these changes, it seemed like January was never going to come, and now it's May. It came and it went. You've been using this for 4 months now. We began reporting the quality and resource use measure data for these elements starting on January 1st. We're looking at skin integrity and the changes in skin integrity. We look at medication reconciliation, resource use measures, in other words, the total estimated spending per beneficiary that Medicare has made. We look at discharge to community. That is, after all, our ultimate goal, is it not? These patients were most often on their own before they came to us, and our end point should be to try to restore them to that level. And finally, we look at all condition risk-adjusted, potentially avoidable hospital readmission rates, because that is a very important goal. It will reduce the spending if we can keep people from being readmitted. So on January 1st, the changes that we've been teaching all through 2016 went into effect. In November of 2015, in preparation and as part of the Impact Act, CMS released this particular final rule. In this document, CMS presented all the specifications for a cross-setting. As Alan said, the Impact Act is across all the settings. So the pressure ulcer quality measure is a cross-setting measure that was adopted for the home health quality reporting program in the calendar year 2016 final rule. The actual outcome measure is the percentage of residents for the other parts of the continuum or patients with pressure ulcers that are new or worsened based on the National Quality Forum number 0678. So we are looking at those patients with pressure ulcers that were new or worsened in the episode of care. The 2017 final rule included these 4 measures. Effective with 2017, these 4 measures were implemented to meet the requirements of the Impact Act. Again, potentially preventable 30-day post-discharge readmission measure. The total estimated Medicare spending per beneficiary. Discharge to community. And drug regimen review conducted with follow-up for the identified issues. As I said before, this is a mixture. Some of this is how you did it, some of it is the end result. Drug regimen review conducted with follow-up for identified issues is a process measure. Process is how you did the work. What did you do? How did you conduct the care so that you addressed this concern? A resource measure is looking at the spending, total estimated Medicare spending per beneficiary. The 2 outcome measures, outcome endpoint result, discharge to community, and the number or percentage of potentially preventable 30-day post-discharge readmissions. That's very important. If the patient returns to the acute care setting within 30 days after you've discharged them from home health services, have we effectively done our jobs? This is a valid measure. If we have effectively done our jobs and the patients have learned and have acquired self-management skills, they should not be having these readmissions unless they are truly unavoidable. In 2015, CMS decided to do a reevaluation of the 81 quality measures. This comprehensive reevaluation resulted in 6 measures being identified for removal from the quality reporting program, and a total of 28 measures being removed from home health quality improvement. Let's take a look at these. These are the quality reporting program measures that were removed. On slide 21, you have the first 6, and you can see that these are all process measures. These process measures are, again, looking at how we provided the care. These were removed from Home Health Compare. In other words, the data was removed, effective with the January 2017 refresh when the data was updated. The measure results will still be displayed on the preview reports for several additional quarters. The measure information will ultimately be removed in 2018 from all of the on-demand agency-level CASPR reports. However, if you have staff that is comfortable with and able to run tally reports on the CASPR website, patient-level data for these measures will still be available to you if you are using these to track your improvement in doing this work. So it would behoove you, if you're not currently running tally reports, to have at least 2 people in your agency familiar with them and comfortable and able to run them so that you will still be able to get patient-level data and use this information for quality improvement projects. These quality improvement measures were also reevaluated and ultimately targeted for removal. There are several slides of these. This first group, again, are the process measures, the how you provided the care. These are the items that are being identified for removal. There are 3 additional process measures on this screen, and then we have 2 potentially avoidable adverse events that are coming off. Number 14 is an end result, the improvement in anxiety. And then you have an additional 2 slides of additional end result goals, quality improvement measures, that are going to be removed. If you think about these measures, for those providers who are working with extremely frail elders, what is the reality that you're going to see an improvement in toileting, an improvement in eating, an improvement in meal preparation? The reality of it when you're caring for an 88, 95-year-old patient. I have one agency that has 20% of their current active patients are 99 and older. Are we thinking these people are going to improve in their urinary incontinence? Not happening. So for you who provide these extremely fragile people, this is logical. If you can keep these measures stable, you're happy. And that's the rest of the list. This measure information is going to be removed in calendar year 2018 from the on-demand agency-level CASPR reports. But again, patient-level data for these measures will still be available if you are able to run the tally reports. Is there anyone here who's not familiar with a tally report? No, that's good. Make sure that if you're not familiar or you're just not comfortable saying it, that you find out what they are, that you learn how to run them, and that you always have at least 2 people in your agency with that institutional knowledge who can do it, so that you will not be without this information. We're going to look in more detail at some definitions. In the specification documents, each of these items, these 6, are defined for the 2 OASIS-based quality measures. The numerator, the denominator, an outcome versus a process measure, a quality episode. This is a definition we've already talked about a little bit. The algorithms for calculating the quality measure itself. And finally, risk adjustment. Risk adjustment's gotten a bad reputation. I know when I teach this, I invariably have agencies that are saying, but it's not fair to me because my raw numbers look better than my risk-adjusted ones. We're going to look at risk adjustment and what the items are that affect the calculation so that you'll have a better understanding of why we do that. The numerator is the number in your denominator who received the care process measure, the how, or the number of patients who experienced that specific outcome, that specific end result. So the numerator is what portion of the denominator achieved the end result or received that process care. The denominator is the number of patients cared for by your agency in that defined time period who were at risk of or eligible for the numerator event or outcome. Okay? Let's take a quick look again at the difference between process and outcome. A process measure evaluates the rate of the home care agency's use of specific evidence-based processes of care. The Home Health Quality Reporting Program process measures are focused on high-risk, high-volume, problem-prone areas for home care providers. You should look at this definition carefully. Look at the specific wording. This wording should be familiar to you. If you have read the draft and final COPs, this is the wording that you will see in there. Evidence-based process. A focus on high-risk, high-volume, problem-prone areas for home health providers. These are the process measures we need to focus on. Outcome measures, end results. Assess the result of the care that was experienced by your patients. How did they respond to the process that you used? Process measures look at what is a desirable care process. And if you have a desirable care process, you'll have a larger numerator relative to the denominator, and this will indicate higher quality of care. An undesirable care process, one that is ineffective, does not prevent patient harm, will have a smaller numerator relative to that denominator or total group, and it will indicate that you are not, if the process is undesirable, you want a small numerator so that you can show that this is not happening. Our quality is good because we're not falling into this problem. With outcome measures, a positive outcome is a larger numerator relative to the denominator for higher quality. With an adverse outcome, this is something you don't want to see happen, right? You want a smaller numerator relative to that denominator because this indicates higher quality. The adverse events, readmissions, emergency room visits, we want as few as possible. So we want the smallest numerator relative to the denominator. Let's look at an example in very simple terms. You are providing care to 10 patients. 3 of them have an identified diagnosis of congestive heart failure. So what percentage of your patients has CHF? Your numerator's 3, your denominator's 10. You do the math, and you know then that 30% of your patients have CHF. I like this example because this is easy math and I can do this. Math is not my strong point, just to ask the person who has to balance my checkbook. This is a graphic. So you have the purple box is your numerator. How many, the raw number, of your patients out of your total group had CHF? The denominator, the darker box, is your total group, and the teal box on the right is your end percentage. Measures that are based on OASIS data are calculated, again, using a quality episode. A quality episode begins with your admission to services or a resumption of care following an inpatient stay. and ends with the discharge, transfer to inpatient facility, or a death. So we know, with the example I gave you before, that a quality episode is a window into that patient's care, with the start or resumption on the left and the discharge transfer on the right, so that we have bracketed it and we know now what happened in between because of the data that we have collected. If you don't submit the required OASIS assessments to calculate the quality measures, this is a failure to comply with the conditions of participation. The quality measure calculation algorithms go through the steps that are used to calculate each of the measures. As we go through the rest of this training from today and tomorrow, we will look at the steps that are used to calculate each of the two new OASIS-based measures that we're going to be looking at. I mentioned risk adjustment. There are 3 types of risk adjustment. The first of these is exclusions. This is patients whose outcomes are not under your control, or for whom the outcome may be unavoidable. They are removed from the calculation completely. Stratification is the second type of a risk adjustment. Patients that have similar risks for that outcome, based on their clinical characteristics or their clinical picture, are grouped together, and the measures calculated separately for each risk group. It makes sense, if you think about it logically, that you would not want to have your risk for falling calculated with everybody in the group all together if I've got 25, 85 and overs with multiple comorbidities and advanced arthritis, and I've got 25, 55 to 65-year-olds with a joint replacement. They're not the same thing. And you need to stratify them and separate them to use the calculation separately so that you can adjust for that risk level. The covariates refers to the specific patient characteristics themselves that might affect that level of risk for a specific outcome. Those are the 3 risk adjustments, and they do matter. They level the playing field between the providers so that when the ultimate data is presented, made available to the public on Home Health Compare, made available to you when you run your CASPER reports, you're able to see a truer picture of where you stand and how you have done. Moving to the assessments themselves. OASIS data is collected at the following time points. These are familiar to you, but this slide is a good teaching tool to pull out and use in the orientation of new staff. We collect OASIS data at the start of care. That's a baseline. Here's where I am. I'm just opening this record. I'm just starting out with this person. Resumption of care gives you a second baseline following an inpatient facility stay. Recertification is done within the last 5 days of each 60-day certification period, and it gives you a progress marker, so to speak. Other follow-up during the episode, significant change in condition. What happened here? There may not have been emergent care or an admission, an inpatient stay, but something significant has happened. You need to document it. It may affect the risk adjustment in some significant way. And so we really should be looking more closely at this assessment and doing it when it is needed. Transfer to an inpatient facility provides that endpoint bracket, as does the discharge from home care or death at home. The start of care, this initial comprehensive assessment, should be completed within 5 days after the start of care date. I know this window seems artificial, and And in order to achieve timely orders, we very often emphasize over and over with our nursing and therapy staff, get that admission done on day one. Get out there, get those consents, get that assessment done, get it written, finished, over with. I just want to give you another point of view. Having been a patient and having had home care services, let me tell you, they gave us the 5 days for a very good reason. From the patient's point of view, it is well nigh impossible to stay completely awake and focused through the whole OASIS assessment on the day of or the day after you come home from the hospital. Trust me, been there. You really need to focus on what's critical today and come back and finish on a second day, because you will get far better data and a better picture of what this person does or does not know and what they can and cannot routinely do at this point in time. There was a reason for that 5 days. The resumption must be completed within 48 hours of return home after the inpatient facility discharge. This window is shorter. It's a resumption. You know quite a bit about this person already. And so it's easier to get the resumption done in a slightly shorter window. These assessments, these 4, must be completed within 48 hours of becoming aware of the disposition. We all know what happens over weekends. We all know what happens when there's 2, 3, 4 days between scheduled clinical visits. You go to call and schedule the visit, you go out there, and it's like, oh, did I forget to tell you? Mom went in the hospital Friday night, and it's Monday or Tuesday. It's not 48 hours from Friday night when she went in. It's 48 hours from when you became aware of the disposition. That applies to the transfer to an inpatient facility, a discharge from home care, a death at home, and that other follow-up. So let's have a practice. Can you find your clickers on your table? Everybody's got them? Okay. Here's your scenario. Mrs. A is admitted to home care. Her start of care assessment is completed. On day 3, Mrs. A is emergently transferred to acute care due to a sudden onset of confusion and fever. She remains hospitalized for 5 days and then returns home requiring IV antibiotic administration. Home care services resume until the antibiotic course is completed. She is then discharged from home care services. Okay, the quality episode is considered completed at what time point? Let's take a look at these. A, when she is transferred to acute care. B, when Mrs. A is discharged from the acute care hospital and home care resumes. When the antibiotic course is completed and Mrs. A is discharged. D, the scenario includes 2 quality episodes, SOC to transfer and ROC to discharge. So press your clicker for A, B, C, or D so that we will know what you think is the correct answer. Very good. 93% of you said D, and that is correct. 7% of our group today were confused by C. They were looking at the only end point. They only considered discharge to community. And that is incorrect because we know that there were actually 2 quality episodes here. That's why you want to remember that bracket scenario. SOC transfer, ROC discharge. The quality episode began with her admission to care, ended with her transfer to the inpatient, began again with the resumption of care, and ended with her discharge to community. Let's try again. See if we can get 100% this time. Mrs. K was admitted to home care services for postoperative management of a large abdominal wound. The start of care assessment is completed. On day 5 of the episode, the assessing clinician notes that the abdominal wound has evidence of dehiscence, and she's complaining of severe abdominal pain. Her physician is immediately contacted, and Mrs. K is transferred back to the acute care and admitted. Okay, which time point completes this quality episode? The completion of the start of care, when she is transferred to the acute care hospital, when she is admitted to the acute care hospital for a qualifying inpatient stay, when Mrs. K is discharged from home care services. Take your clicker, select A, B, C, or D. I'm going to give you a few seconds to do that. I hear some discussion this time. Good. Very good. Okay, has everybody decided? Are we all comfortable with this? You ready? Okay, let's find out how we did. Aha. It appears to me that we have a divided opinion. I could tell from all the murmuring out there. A little over 1/3 think that the the end of this quality episode was B, when she was transferred to the hospital. 2/3 are saying the correct answer is C, when she was admitted to the hospital for a qualifying inpatient stay. And 3% are saying when she's discharged. Anybody want to change their mind? And the correct answer is C, when Mrs. K is admitted to the acute care hospital for the qualifying inpatient stay. The rationale for this is a quality episode begins with her admission, we all agreed on that, but ends with the discharge, transfer to an inpatient facility, or her death. Okay? So simply being transferred by ambulance out of the house is not a transfer it's not a transfer to the inpatient facility itself. Inpatient is the critical word here. Let's look at reporting compliance. In calendar year 2015, the Home Health Final Rule, CMS established a pay-for-reporting performance requirement to support measuring provider compliance with the existing quality reporting program requirements. In other words, if you did not submit the quality episode data, you would have a penalty to pay. Provider compliance is being measured using a quality assessment only metric. This is what the metric looks like in a graphic format. The numerator is the number of assessments submitted that can be used for quality measurement. Your denominator is the total number of assessments submitted that should be usable for quality measurement. When you do the calculation, your level of compliance percentage is what CMS is looking at. The first performance period covered the time frame from 7/1/15 through 6/30/16. The minimum acceptable compliance standard was 70%. Agencies who fell below that 70% would expect to see a 2% reduction in their payments through calendar year of 2017. The national provider level of compliance for this time period was 96%. So we clearly made the cut because this is a condition of participation, that we comply with this. The next minimum compliance standard for 7/1/16 through 6/30/17 is 80%. Agencies who fall below will see a 2 percentage point reduction in 2018. CMS's ultimate goal is to ensure that all home health agencies achieve a quality reporting compliance rate of 90% or more. Our first measure was 96%. It's logical to believe that we will continue to perform at this level and that we should continue to set our sights on the best possible target of 100% compliance. These quality assessments are the foundation for quality episode measurement, for knowing how we have performed and how we are doing. Information about how to determine your compliance rate is available in the QAO report. The interim and annual performance reports are available at this web link. And if you have these slides up, this is a live hyperlink. You are able to click here and go directly to that. These reports will be automatically generated and saved into your provider shared folder in Casper. Okay? Let me just ask a quick polling question of my own. How many of you are looking at these on a regular basis? Well, that's not too bad. Try to make sure that you do check these. Even though overall the compliance rate is 96%, you do want to keep an eye on how your agency's doing, and you do want to carefully track all of your OASIS submission and validation reports on a regular basis to make sure that there's not a wrinkle in the system, so that everything is in fact being submitted, transmitted, and accepted. The minimum quality reporting compliance rate for the performance period of 7/1/16 through 6/30/17 is what percentage? This is an easy one. We've just gone over this. 70%, 80, 85, or 90. Okay, are we all set here? Make sure you pick up your clicker and select A, B, C, or D. It gives us a full 30 seconds. I'm not sure that we really need it. We've covered this pretty well. And 80% of you selected B. 80%. 88% of you. That's pretty good. We've got a small group of people looking at A and D. And of course, the correct answer is 80%. That's the minimum quality reporting compliance rate for this current year, 16 to 17. We know that we've been performing at 96%. Agencies with a compliance level below 80% for the performance period of 7/1/16 through 6/30/17 will see a 2% reduction in their payments for calendar year 2018. True or false? Yeah, I hear it all over the room. Okay. Make sure you check your clicker, number 1 or number 2. And you're correct. 97% of you said that was true, and it is. Although, again, with a 96% compliance rate, I don't think very many agencies are going to be seeing that reduction. Thank goodness. Let's take a quick moment and look at some of the resources that are available to you. As we go through these, I do want to make another recommendation to you. This is, and I freely admit this is the teacher in me popping out at odd moments. When you go through these resources, and over the next 2 days, as we talk about different resources, different web links that are available to you, I would strongly recommend that whatever laptop you use most often in your office for your daily activities, you want to set aside a list of favorites that includes these specific links so that you will always have at your fingertips the information you need. Different items, different sections of the CMS website itself, the OASIS resources, the beneficiary notice information manual, all of these kinds of resources should be in a favorites folder, all there as specific web links right there on your desktop, so that you can always access them. Okay? As administrators, as clinical managers, as supervisors, you want this information at your fingertips. The best thing you can do for your staff is not to try to be an encyclopedia, but rather to always know where you can find the information you need very quickly and readily. So let's look at what's available to you. If you go to the cms.gov webpage, go to the download section that's always at the bottom, cms.gov, Medicare, Home Health Quality Initiative, OASIS datasets. You're going to find the OASIS C2 items. The second one takes you to the user's manual as of 12/12/2016. These are critical pieces of information. You definitely want to have them available to you. Here's the web link that will take you to the Q&A. It's on the left-hand side navigation bar. It's the 10th bullet down. In the related links, you want to look at the OASIS FAQs. These are questions and answers that have evolved over many years of experience. We've been doing OASIS a long time. And every once in a while, a question will come up and you look at it and you think, I should know this. But it's on the tip of your tongue. You can't quite come up with the exact specific wording of the answer. You need to go here. There's a special part here where you can email a link in to submit questions of your own. This is what the page looks like. I know I see several of you have your laptops and your tablets. You may have already gone to this page. This is the Home Health Agency Q&A. It really is worth it to take the time to go to the website and cruise around, take a look at what's there, and bookmark those pieces that are most important to you. This particular link, the cms.gov Quality Initiatives Patient Assessment Instruments, this is going to take you to more information about the quality measures. You go to the download section at the very bottom, and you're going to find here the measure specifications from the final rule. You'll find the measure specs for the pressure ulcer. You're going to find a current list of all the measures that are being removed and the tables. There's the page itself. Here are some compliance links so that you can go here and look at the quality reporting requirements. This will give you all the background information that you need, so that if you have the opportunity, you want to go to these different locations, read through them, bookmark the pieces that you need, download what you need if it's not going to be changing. These here are all live links. Some of these Alan went through already, so I'm not going to repeat them. But I will say I do want to call your attention to the help desk at the bottom. Earlier, I made the comment that you should always have at least 2 people in your agency that are comfortable and familiar with Tally. You also need to be sure that you maintain institutional knowledge. It's critically important that you always have a primary person and a backup person who know exactly how to go into Casper, run your on-demand reports, know what they mean, know how to interpret them, know how to save them, know how to track different measures sequentially through them. It's not enough to have one person. You absolutely need a backup. Things happen. Emergencies happen. I can't tell you how many times we get calls saying, oh my God, she was the only person who knew the passwords and knew how to get in, and now she had an accident and I can't even talk to her. And now what are you going to do? You need that backup person. If you don't have it, if you can't find what you need, the help desk is there to help you. I work with them regularly. I am telling you, they are very helpful, very efficient, and very welcoming of your calls and your questions. So don't hesitate, but make sure that you have these links and you keep them on your desktop so you can always get the people that you need. Okay, I've managed to finish a few minutes early. A lot of this information is familiar to you, so I'm going to leave it open for questions. Are there any questions for me or for Alan? Yes, sir. There's a microphone, sir, right over there, diagonally across.
Good morning. I understand this is a revolution in healthcare industry, but my question for Dr. Levitt, one of your slides here saying under standardized data, goals and guiding principles is reduction in provider burden. I don't think this is true, because actually we are living in an era of too much regulations that really affect our capability of providing the best care that we can. I personally leading an agency with a star rating of 4 out of 5, and we are hoping that we can score 5 out of 5. However, according to these too much regulations, there is too much burden on us to provide this quality of care. You know, I just give you a small example so we can make the picture clear. If you got a referral from a hospital and you have the admitting order for home health care by a nurse, and then you contact the hospital for the clinical documentation, and they tell you the hospitalist is the one who signed the order and you need to contact your PCP for that patient. If you send the nurse within 48 hours to admit the patient, and you try to get the supported documentation so you can match your OASIS data to the clinical documentation, I don't think anybody is going to be able to answer this question that we truly get this documentation within 48 hours. This is impossible. And to advise the patient to go to her or his PCP to get the completed documentation, that's another maybe a week or two to get this documentation. So it's just too much burden. You penalize us as a home care providers for somebody else who doesn't want to do their job. So my question to you is there any governing rule here that really we can get what we need, you know, in a timely manner? Thank you.
What we are trying to do in terms of standardizing data is done with the goal of decreasing provider burden specifically. And the reason that we say that, and I believe that, is a couple of reasons. First is that I'm from your world, and so I came to CMS and with the experiences of what real world is like, and how regulations upon regulations, you know, make it more burdensome. The concept of standardizing data and of some of the measure domains of the Impact Act are done with that in mind and to try to decrease that. First of all, the transfer of health, a measure domain in terms of trying to make sure that the information that gets transferred from setting of care to setting of care will hopefully reduce burden, particularly in home health, because of the amount of time that I used to see agencies and nurses trying to track down the right information that was, you know, to be followed and continued on patient. Concept of longitudinal data that can be used in home health and in all other settings is done with the idea that we will speak the same language, and by speaking that same language will also decrease the burden. Trying to get data that is collected once and be reusable is also done with the idea that we'll be able to use that in many different ways and then hopefully reduce burden. the Impact Act legislation is specific on trying to reduce burden in that when at all possible, as we are making this transition and transformation to using standardized data throughout post-acute care settings, is that we try to limit duplication of information as much as possible. We try to do that and are sensitive to that. There are times where there may be what appears to be duplication. That's because there may be other purposes that for that data that need to transition to the standardized data as well. I certainly will take your comments back to my colleagues throughout CMS who, again, are working on some of the issues that you were discussing. But know that particularly in our shop, in the Home Health Quality Reporting Program, we try to be as sensitive as possible. The fact that agencies are all different sizes, and we have small agencies that have to do the same type of work as large agencies, makes us particularly sensitive to that. Whatever we are asking those agencies, we try to limit the burden as much as possible because it affects the small agencies more because they have less staff to take care of that. So, but thank you for your question.
I have a question, and just to piggyback off the gentleman. With the resumption of care, we know we have, with our star ratings, we kind of get penalized if we're not out there within 48 hours. Are they looking at any regulations currently on resumption of care? Because there's some doctors that do order based on the patient care and need, that it's beyond the 48 hours, but if we don't get out there, we'll still penalize, even though the physician requested the care to be delayed. For an example, for a wound care, that the patient's on a wound vac, and they want the nurse to go out 3 days later because it's not due to be changed. But we get penalized if we're not out there within 48 hours. Is there going to be a regulation coming with that, or is that something they're looking at currently?
I assume you're talking about the timely initiation of care measure. Okay. Well, I always love to look at my Oasis Answers people sitting back over there for questions such as that. One comment first was really interesting in the development of star ratings was that star ratings were done with certain criteria in terms of measures being used, and the criteria were that these were measures that were out there for a long time on Home Health Compare. And one of the interesting observations we've had with star ratings is that we rarely, if ever, had questions about the measures and the results of the measures until suddenly the star ratings came out, and suddenly everybody is interested in these same measures and measure results. So in some ways it reassures me that going ahead and doing the star ratings was important because it's forced all of us to look at the quality and the quality measures that we have, and maybe some of the situations where it's felt that the specifications of whatever the measures are may not properly reflect what we wish to have those measures do. As to the timing of the measure itself, I'm really not the best person in terms of answering how those how that measure works. But I strongly suggest submit the question and the issue to the mailbox that was there, and certainly we do have the people and the right people who can help to answer that. Oh, I'm sorry.
I said, I'm sorry. We did, but the response was there's no regulation, so it's basically in general it is what it is.
Why don't you send the question again and mention that you were, asked that question as part of this?
And to answer that, I believe in the new COPs, that regulation is changing. If the new COPs are changing, that regulation is changing anyway. So look in the new COPs, and you can find that. Question I have, though, is with the OASIS, you have clinicians out there that have so much, they're trying to take care of a patient, okay? They have so much to do to take care of this patient, to try to provide incredible, excellent care to this patient. And we have an OASIS document that I understand why we're doing it and why we have to fill it out. The problem, one of the problems, and I do so much teaching with this, is the consistency of the questions. When you have reverse scales on some of them, it becomes very burdensome to a clinician. So I don't understand, like we have this new GG question that I understand came from probably a post-acute care setting, but it has a reverse scale. So everything else that you're answering on your M1800 questions goes one way until you get to this one question, and then it's totally opposite. It's very difficult for clinicians, and there's other questions like that in there. It would be much easier, and I don't know whether this is done on purpose to make sure they're really looking at things, but we have in our agency that you start from the bottom up. You start at the bottom because that's usually the worst and work your way up so you can make sure you're answering correctly. But when you throw something like this in there, it's very difficult when you're trying to be, and from a teacher's aspect, that's really not how things should work.
And again, as I said, this is the start. One of the great challenges that's going to happen with that question, and I'm sure many other data elements that come up, is that we all do speak the same, we all do speak different languages in the different settings. And what we're trying to do is we're trying to develop a single way of looking at those data elements. And so your concern is similar to the same questions and concerns in other settings, as well as we make this transition from the way that we've coded and spoke, one way versus another. And all I could say is that, again, we develop these items and try to score and code these items so that they can be the most reliable and valid items throughout all the different settings of care, and so that they can longitudinally follow the patient. And I appreciate the fact that you and your agency, and hopefully everyone else, is continuing with this transition and understanding that that's why we're doing it in the first place. There is method to our madness. Okay. Oh, one question.
Dr. Levitt, and this may be the wrong forum. I'm sorry, I'm right here.
Okay.
This may not be the right forum. I appreciate that. Can you speak to the FHIR standard, or the VNA, or even the vendor-neutral architecture, or the personal health record concept? Any trending? Any comments one way or the other?
No, I'm really not the right person to speak to those things. Okay. Any? Oh, my time is up. Okay, the time's up. Okay, but thank you very much. Continue. You have questions, please send the questions in. Continue to send it in. We want to hear how things are going. We understand that there's going to be, during this transition that we're doing, that the devil is going to be in the details. But the goal and the importance of what we're doing, really, you must recognize that as we go through all of these things. So, but thank you again, and thanks for inviting me.